Hello and welcome to the Mead with Mead channel. Today I'll be talking about pericarditis, which is an inflammation of the pericardium. The pericardium is a protective sac that surrounds the heart. Normally there is a small amount of fluid inside the pericardial space, and this helps the heart move smoothly as it beats. But if too much fluid collects in this space, it can start to compress the heart, which can prevent the heart from filling properly with the blood, and then the heart cannot pump effectively. And this dangerous condition is called cardiac tamponade, and it can become a life-threatening condition. For the causes, pericarditis has a similar etiology to myocarditis. If you haven't watched the myocarditis video, you can go to the channel and watch it as well. The most common cause is viral infection, including Coxsackie virus, influenza, adenovirus, and coronavirus. It can also be caused by bacterial infections, especially tuberculosis, as well as fungal or parasitic infections. Non-infectious causes include autoimmune diseases like SLE, rheumatoid arthritis, Kawasaki, and sarcoidosis. Other causes include certain drugs, after myocardial infarction, and tumors affecting the pericardium. Pericarditis can be classified by duration and by type. Acute pericarditis lasts less than 1 month, subacute from 1 to 3 months, and chronic lasts more than 3 months. When it comes to type classifications, we have, for example, dry pericarditis, which means there is no pericardial effusion. And then we have effusive pericarditis, which means there is a fluid collected in the pericardial space. And there is also effusive constrictive pericarditis, which means there is both fluid and thickening of the pericardium, which can restrict the heart's pumping ability. And the most dangerous form is pericarditis with cardiac tamponade, where fluid compresses the heart and prevents proper filling. Clinically, pericarditis usually presents with retrosternal chest pain, which means behind the sternum, and also pleuritic chest pain. The pain gets worse with coughing or deep inspiration, and it typically improves when the patient is leaning forward. Patients may also have fever, chills, tachypnea, dry cough, dyspnea, which means difficulty breathing, or arrhythmias. And the pain can sometimes radiate to the left trapezius because of phrenic nerve irritation. On examination, the classic finding is a pericardial friction rub. If constrictive pericarditis develops, patients can show signs of right-sided heart failure, such as jugular venous distension and peripheral pitting edema. And if cardiac tamponade occurs, remember Beck's triad, which is hypotension, jugular venous distension, and muffled heart sounds. For the diagnosis, we start with ECG, and typical findings are diffuse ST segment elevation and also PR depression. If there is a large pericardial effusion, the ECG may show low QRS voltage or electrical alternance. Pericarditis can also trigger arrhythmias such as atrial fibrillation. We can also take a blood test, which usually show inflammation. So CRP and ESR can be elevated, and on the complete blood count, you can see leukocytosis or increased leukocyte counts. Troponin can also be elevated if the myocardium is also involved, and then we have myopericarditis. Echocardiography is very important to look for potential pericardial effusion and if there is signs of tamponade. Other additional testing that can be used is chest X-ray, CT, or cardiac MRI. Moving on to management, for the non-pharmacological, we advise the patient to avoid physical exercise for at least 1 month until there is a resolution of symptoms and the biomarkers such as CRP or the leukocytosis has normalized. And when it comes to pharmacological treatment, usually it is with anti-inflammatory drugs. For example, aspirin or NSAIDs together with colchicine An example of NSAIDs such as ibuprofen or indomethacin or naproxen. And if the treatment fails, you can consider adding glucocorticoids such as prednisolone. In patients with cardiac tamponade, or if the patient is symptomatic with a large pericardial effusion, we can perform a procedure called pericardiocentesis, which means that we insert a needle into the pericardial space to drain excess fluid. And usually it is under ultrasound or through CT guidance. And the fluid should be removed slowly and carefully, because if you drain it rapidly, that can cause pericardial decompression syndrome. And if the effusion is purulent, or if pericardiocentesis cannot be done, surgical drainage might be needed. And surgical options include pericardiotomy, which means that we create an opening in the pericardium to drain fluid, and pericardiectomy, where parts or most of the pericardium is removed, mainly in chronic constrictive pericarditis and when the medical treatment fails. That's it from me today. I hope this video gave you a clear overview of pericarditis. If you found this video helpful, please like, share, and subscribe to the channel, and thank you for watching.